So in connective tissue graft harvesting procedure have been widely reported in the literature in order to minimize the patient discomfort in the palate with compared to secondary intention wound healing, that is the typical wound healing in the case of free gingival graft. The first one, or one of the most widely used, was the trapdoor approach, in which a door of the same dimension of the graft is open, then the graft is taken, and finally the flap is put back to achieve primary intention wound healing. The problem of this technique is that since you have two vertical release incisions in the palate, the risk of flap necrosis is extremely high. If there is necrosis of the primary flap, patient pain is 6 times more than in the case of secondary intention wound healing due to the necrosis. So many authors have tried to change. Somebody suggested to make only the mesial vertical release incision in order to reduce the risk of flap necrosis. And finally, the most widely used is the so-called envelope technique or single incision technique, in which only one incision is made. What was the problem of this incision? It's much more difficult, obviously, with respect to the trapdoor. It is better because less risky to necrosis, because there is no vertical release incision in the palate, but there is one main problem, that you have to increase the dimension of your incision, and you have to increase the dimension of blind dissection into the palate with respect to the dimension of the graft, obviously. Because if you want to take a certain amount of graft and you have to get inside this envelope flap in the palate and to get access to the apical, distal, and mesial angle of the graft, you have to open this envelope much more than the dimension of the graft. Or you take a graft that is much bigger in the coronal direction with respect to the apical direction, and this is not good. And so when you are when you can perform this blind incision in the palate to get access more apical and more distal with respect to the area to be grafted. Obviously, not in the area of the 7 tooth, not in the area of the 6. 6, it's not a good area because it's very thin. 7, it's not a good area because you cannot make a blind incision more distal and more apical at the level of the 7 because of the problem of vessels. And so now, if you want to make this technique with no risk at all, you have to perform it in the area of the premolar, which is called anterior palate. The area of the premolar, it's a completely different story with respect to the area of the molar in terms of quality of the palate. The area of the premolar is called also anterior palate. It seems to be thick because there are the rugae and there is a very thick layer of fatty and glandular tissue, which is called submucosa. The area of the molar is much thinner, but the quality is better because there is more dense, collagen-rich connective tissue. So the two area is a completely different story. If you go into the area in the premolar and make a double layer procedure, namely you preserve a primary flap, you remove the connective tissue and you close, the connective tissue, the best connective tissue you have is that one you leave in the palate for the primary flap, because if you don't leave connective tissue in the primary flap goes to necrosis and the pain is greater. And so once the flap has been opened in the area of the premolar, most of the time you find a yellow tissue, glandular tissue, fatty, completely useless to achieve root coverage, and most of it is going to resorb in the first year time. While in the area in the molar, yes, it's much better. And as much as you go distal towards the tuberosity, you have the better quality of the connective tissue. But you know that as much as you go distal, as much as you go toward the 7, it's really risky to perform the single incision technique, because you have to make a very dangerous incision, more apical, more distal, blind in the palate at the level of the 7. Nobody will make, because obviously in that area there could be some vessel, even if it's not the big arteria, but there could be also some vessel that can create problem, at least during the harvesting procedure. And then there is the problem of the pain, and then there is the problem of the bleeding. What does pain and bleeding depends on? They really depends on first and second intention wound healing. In my knowledge, bleeding and pain depends on how wide, how big are vessels and nerves that are cut during the surgical procedure. And so if you want to compare in a very fair way the two procedures, namely one healing by secondary intention with one healing by first intention, you have to fix how much connective tissue do you want to take. In other terms, if I want to graft 1 millimeter connective tissue thickness, and if I want to make the single incision technique, I have to take at least 1 millimeter of thickness for the covering flap, then I take 1 millimeter of connective tissue for the graft, and then I close. It means that I was about 2 millimeter and 2 millimeter and a half deep in the palate. Why? If I want to take 1 millimeter of free gingival graft that can be desepithelialized and remove only the epithelium, I can go only 1 millimeter, 1 millimeter point 2 deep in the palate. Not 2.5, as I have to do in the case I want to preserve the primary flap. So, from one side, yes, the healing is improved by healing first intention because of the primary flap, but from the other side, you go more than 1 millimeter deep in the palate, and so you go in the submucosal tissue where you have bigger vessels and bigger nerve. So if you compare the pain, there's no difference if you maintain as a firm point the thickness of the connective tissue graft. So it's not true. It's not true that the two procedures make different in pain and bleeding. Obviously, if you make 2 millimeter deep healing by secondary intention and 2 millimeters deep healing by first intention, it's better first intention. But that's obvious. But you don't have to go 2 millimeter deep to have the same quality, the same type of thickness. And in terms of quality, what is the quality of the connective tissue in the area of the premolar, where you have the rugae, where you have the anterior palate? Once you open the flap, it's immediately yellow. And so if it's immediately yellow, what do? You close it, or you graft fatty and glandular tissue. Sometimes you have thick, enormously thick palate. But how much connective tissue do you have in this palate? So you have to taste this palate. When you make anesthesia, when you probe this soft tissue, if it's mobile, it means that most of it is submucosa. And if it's only submucosa, you cannot take any other technique that free gingival graft that can be desepithelialized extraorally, because you don't have enough connective tissue to make the two layers. And even if it's thick, even if it's made of dense collagen-rich connective tissue, if you remove only 1 millimeter thick, you are so superficial that it does not bleed at all, because you don't reach the submucosa. It does not bleed at all. It's like completely painless, because it's so superficial that it's like an abrasion. And so you don't make it bleed, and there's no pain at all. So there is no reason anymore to make the single incision technique, not to improve the pain, not to improve the quality, because the pain is exactly the same, but the quality of the connective tissue to be harvested is extremely, extremely much more poor. And if there is some situation in which you really need thicker, you cannot go deep in the palate. As much as you go deep, you have fatty and glandular tissue, more pain and more bleeding. What you have to do is to increase the length of your harvesting procedure. Length means mesial-distal. which does not modify too much or at all, according to the literature, the pain. And then you can bend your desepithelialized connective tissue graft and achieve a connective tissue thickness by joining the inner aspect of your connective tissue graft per 2 or per 3, depends how long did you take your graft. And now you can really achieve 3 millimeter, 3.5 millimeters of connective tissue thickness, not fatty and glandular tissue thickness. Connective tissue is white. In Italy, connective tissue is white. All over the world, connective tissue is white. And so if you are speaking about connective tissue graft, we should use good quality of the connective tissue. And since this connective tissue is so good in quality, you can take also very, very thin, because its stability, short and long term, is much more compared to thicker connective tissue that are more rich of fatty and glandular tissue. And it's more than enough to make 2 mattress suture, which make the 2 inner aspects of the connective tissue graft facing each other in order to reach the right thickness. Even more, that one you can take in the thicker palate of the word, but with no connective tissue enough in order to perform the right quality of graft. And which technique are we using to take this graft, free gingival graft, very, very thin, minimally invasive, that is desepithelialized extraorally? We make the horizontal incision of the right dimension, which is the same dimension of the graft. We make 2 vertical release incision of the same dimension, which is the dimension of the graft we intend to graft. And we never make, at the beginning, the apical incision, because it's the apical incision that make the palate bleeding more. So we use the mesial vertical release incision in order to calibrate the thickness of the graft. And once this graft has been defined in thickness, we maintain the graft, the knife parallel to the graft, and for this reason it's very useful to use the 15C blade, so we don't make too many cuts, but very, very regular cut from the mesial to the distal vertical release incision. Now we make it deeper, the vertical release incision, and now the whole graft from the mesial to the distal is probable, and so we pinset, we take the graft, and we make the apical incision. Only now we make it deeper and deeper until the whole graft is removed. How long does this procedure take? No more than 5 minutes. Then we take some substitute in collagen that is fixed with 1 mattress suture, which is crossed around the buccal surface of the adjacent tooth and fixed in place. But this is so superficial wound that it does not bleed at all. How long does it take, this procedure? 5 minutes. How long does it take to make the single incision technique? 15 minutes. So it means that you stay in the palate of your patient 10 minutes more. Now, if you make a comparison, and if you ask the patient, one time you make the single incision technique, the other time you make this technique, and you stay 10 minutes more with a lot of bleeding in the palate, and ask the patient, which of the 2 procedures do you prefer to repeat? And then you tell me what is their answer. Because you stay 10 minutes more with a lot of bleeding, with a lot of suction, in order to remove the second layer, to fix everything in the single incision, while when you are suturing, while you are still in the palate of the patient, you know what I am doing? I am on my table with my graft only. My patient is resting. I can remove the inner aspect of the graft that is fatty and glandular, if it's yellow, and still have the right thickness of connective tissue that now has to be desepitalized. Desepitalization is done with the 15C blade, because you need a very uniform cut, one-shot cut, in order to remove 1 layer, because you don't have to remove only the keratinized tissue. the external layer. You have to remove the basal layer. So about 2 millimeters, 0.2 millimeters of tissue must be cut away in a single shot incision. In the most coronal aspect, that one facing the teeth when the graft was in the palate, it's always better to make a perpendicular incision to remove some remnants of epithelium that frequently remain in this area, because it's very hard to make a perpendicular incision and rotate it adequately in order to maintain the right thickness to the connective tissue, to the most coronal aspect, to your connective tissue graft. And now, after this very quite simple procedure that is always done after magnification with the air perpendicularly oriented with respect to the graft in order to see the difference in light reflection of the epithelium, which is rough, compared to the connective tissue, which is smooth. And you can feel the difference with the blade from the rough surface of the epithelium with the smooth surface of the connective tissue. And also, if you have to take long graft, because you have to treat many gingival recession, or you have a very thin palate and you need a thick palate, and so you have to bend your connective tissue, so you have to go from the premolar to the molar area, which is the only technique you can make.